Hello, everyone. My name is Lizzie Stewart. We are pleased that you all could join us for this week's lecture in Volume 10 of our No Neuropsychology didactic series that brings you lectures from experts in the field covering different topics each week. This series was created by trainees and early career neuropsychologists, including standing members of the No Neuropsychology Board, as well as members of the No Neuropsychology Committee. Before we start our lecture, one of the main goals of No Neuropsychology is to provide free, high-quality didactic content to our audience. Every No Neuropsychology and No Neuroanatomy lecture is available on our YouTube channel. Be sure to check it out, subscribe, and like our lectures to get first access to new content. New to No Neuropsychology is our collaboration with APPCN to bring you learning and discussion questions that are provided with specific lectures content. You can access these on our website and through APPCN. Here are the disclaimers for the series. This training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions can be submitted via the Q&A box on the lower left of your screen, and a recording of today's lecture will be provided on our website and YouTube channel later this week. Now it is my pleasure to introduce Dr. Elise Turner for today's lecture entitled Pediatric Solid Organ Failure in Transplantation. Dr. Elise Turner is an early career faculty member at Children's Hospital of Colorado and the University of Colorado's School of Medicine. Her primary clinical work includes both CNS and non-CNS oncology populations, but she also sees a variety of medically and neurologically complex patients in her clinical practice, including those who have undergone solid organ transplantation. She is also interested in the development and implementation of a tiered neuropsychological care in clinical practice across medically complex patient populations. Now, please join me in welcoming Dr. Elise Turner.
Thank you. I'm just going to go ahead and share my slides here. Those and then, okay, hopefully you see the full screened slide there. So thank you
Turner,
for
I
that
think we see,
introduction.
sorry, Dr. Turner,
Oh,
I
go
think we
ahead.
see your
The
notes
notes
slides. Yeah.
version. Okay,
Mhm.
let me see if I do that. Does that work?
Perfect.
Okay, perfect. Thank you. Well, thank you again for that introduction. Thank you, No Neuropsychology, for having me. And I am excited to talk to you guys today a little bit about pediatric solid organ failure in transplantation. But I'll first say that I have no financial relationships to disclose. Just a little bit of an overview of my talk today. So I will provide some kind of broader information on solid organ failure and transplant to start. And then I will take a deeper dive into the three most common solid organ transplants in pediatrics, so kidney, liver, and heart transplantation. So I'll talk a little bit about what each organ does, how it impacts the central nervous system, and then what the kind of existing literature says about cognitive and neurodevelopmental outcomes in those patient populations. And then the last bit I will talk through shares some cognitive and developmental care guidelines for pediatric neuropsychologists, as well as special considerations for us as neuropsychologists to focus on when working with this patient population. So that'll be today's presentation to get us started here. So what is solid organ transplant? So this is really considered standard therapy for pediatric end-stage organ failure. So there are many different diseases, complications, or injuries to various solid organs, but not all of them lead to organ failure. For those that do reach what we consider end-stage organ failure, this is when a vital organ stops working on its own and can no longer support the body's need. Then this is when solid organ transplant is considered necessary for survival. Just some statistics here from Donate Life from last year. So annually in the United States, there are over 2,100 children that are on a transplant waiting list. And a large portion of them are very young, so in that 1 to 5 year range. In 2023, they had data that said that about 1,900 children received life-saving transplants in the calendar year. And this came from about 900 organ donors. So what happens when a patient is experiencing organ failure? And they're considering transplant. So they undergo a multidisciplinary transplant evaluation prior to being put on a transplant waitlist. So this includes, again, a multidisciplinary review of a patient's medical status, their psychological readiness for transplant, as well as the supports that the patient and the family have in place, or any gaps that they need to fill in those areas prior to being put on a transplant waiting list. There are some pediatric specific waiting lists, and then there are some that are combined with adults. So the three kind of most common transplant populations, like I talked about on the previous slide in pediatrics, are heart, liver, and kidney transplantation. But there's also different kind of gastrointestinal transplant, pancreatic, and lung transplant patients, as well as many others that are more common in the adult setting or kind of early in their medical advancement. For pediatric patients and adult patients too, but in pediatrics, the wait list between getting put, or the wait between getting put on a wait list to transplantation can really vary. Sometimes this happens as quickly as within a few weeks, and sometimes this may take longer than a year. And so it's really variable from patient to patient. What's something that's a little bit kind of interesting to know about pediatric solid organ transplantation is that being put on a transplant waiting list before you turn 18 years old gives you what you call kind of pediatric priority status. And so it kind of ups your status of need on a wait list. It makes you priority compared to kind of adults. It doesn't matter if a patient turns 18 while they are on the wait list, as long as you're put on the wait list prior to 18 years old or your 18th birthday, you are considered to have this pediatric priority status. So overall, what we've seen in the last several decades in pediatric solid organ transplant is an increase in survival rates in this patient population. So across all organ types, survival rate is now over 85% in solid organ transplant recipients. And like many of the other patient populations that we see in neuropsychology, this is due to a variety of medical advancements in recent years. So advancements in different surgical techniques, new immunosuppressant medications that have become available and are more effective, as well as actually different organ matching and procurement techniques as well. So all of this to say that that increased survival rate is bringing these patients through our door more in pediatric neuropsychology. So this really is a growing area within our field. And I want to kind of caveat or give kind of a caveat before getting into the rest of the presentation that there is really kind of a small literature base in terms of cognitive and neurodevelopmental outcomes in solid organ transplantation. So a lot of these have cross-sectional study designs and small sample sizes. So there's still a lot more to be learned about kind of the profiles and risk factors of patients who have undergone solid organ transplantation. But the way we kind of think about it at this time, especially in the research, is what are those kind of pre-transplant factors? Is the transplant process itself having any impact? And what are kind of transplant-related complications that all kind of come together to pose some sort of risk for cognition and neurodevelopment over time? So the first population that I will start with is kidney failure and kidney transplantation. In neuropsychology, it feels like we spend a lot of time focused on the brain and the central nervous system and what that organ does. But we don't really talk about other organs in the body and how that might impact our brain and central nervous system, and then have kind of downstream effects on cognition and neurodevelopment. So again, for each kind of population that I highlight here, I want to talk a little bit about what that organ does to give that background information. So what do our kidneys do? So the kidneys have many, many functions, which I have kind of many of them listed out right here. But one of the primary functions is going to be to regulate our urinary output. So our kidneys are monitoring substances found in our blood and regularly excrete kind of excess or waste products out of the blood. Some of these are not considered necessarily toxic substances at kind of normal levels. So different dietary substances like salt, water, and minerals, the kidneys just prevent them from accumulating so they don't become harmful. And then some of them are considered kind of more waste or toxic products like urea. Urea in particular can accumulate when there is kidney dysfunction. And this is something we call uremia. So when there's high rates of this waste product circulating in the blood. And so what happens when this uremia is occurring is that then circulates to the brain and can have a negative impact on our central nervous system, including what's been documented as changes in brain metabolism, disruption to neuronal myelination and synaptic development, as well as disrupted autoregulation of cerebral perfusion, which can then compromise oxygen supply to the brain. What the kidneys are also responsible for is regulating our blood pressure. So high blood pressure or hypertension can occur with kidney dysfunction and failure. And what this has been shown to do is also impact the central nervous system, in particular through disruption to white matter integrity and changes in brain microvasculature. Both hypertension and uremia also put patients at higher risk for stroke. So just another neurological complication that can have neuropsychological implications. So now that we know a little bit about what the kidney does, I'll talk a little bit more about kidney failure, presentation of this, and then transplantation. So the primary medical precursor to kidney failure is something called chronic kidney disease or CKD. This is really an umbrella term for a variety of etiologies of kidney disease and failure. So anything that's kind of damaging or causing the kidneys to be dysfunctional. Again, broad umbrella term. Another umbrella term under the CKD umbrella term is this congenital abnormalities of the kidney and urinary tract. This is a variety of different kind of congenital disorders. It can include things like hydronephrosis, which is when there's a stretching of the kidney with blockage in the urinary tract, or things like dysplastic or hypoplastic kidneys, where our kidneys are not fully developing while in the womb. There's also a variety of genetic conditions like polycystic kidney disease that can lead to CKD, as well as diseases that affect what's called the glomeruli. So these are tiny filters in your kidney where your blood is cleaned from those waste products. So again, kind of a really big umbrella term, but in the literature, it's all going to fall under this chronic kidney disease diagnosis or name. CKD is described in stages, with stage 5 being considered what is also called end stage renal disease or end stage kidney failure. So in later stages, between kind of 1 and 5, patients are often receiving what's called dialysis. So this is a treatment that essentially does the work of the kidneys for the body. So it's removing waste products and excess fluid from the blood. So what happens is there's a machine that a patient is hooked up to that removes body from the blood, filters it through essentially an artificial kidney, and then returns the clean blood back to the body. This can be really burdensome for patients. These treatments can be kind of 3 to 5 hours long and need to happen multiple times a week, especially with greater disease severity. For those that are experiencing kind of stage 5 kidney failure, kidney transplantation is considered the superior treatment option over dialysis. And sometimes dialysis is used just to bridge a patient to transplantation. For many of our solid organ populations, we see higher rates of transplantation in younger kiddos, so that 5 and under age range. And while kidney transplantation is definitely no kind of exception to this, it also has higher rates of transplantation in adolescents compared to other organs. So you're more likely to see patients that are getting transplanted across the kind of pediatric to adolescence or childhood to adolescence kind of age ranges here compared to other organ failure populations. So on this slide, I'm going to talk a little bit about what research is out there in terms of cognitive and neurodevelopmental outcomes in kidney failure and transplant populations. So just to explain this graphic a little bit, because I'll be filling in these squares here as I talk, I have an arrow going through the middle there. So everything on the left-hand side is going to describe outcomes that were seen in the pre-transplant phase in this patient population. And then everything on the right is going to focus on outcomes in the post-transplant phase. Everything above that arrow is going to focus on patients in that kind of 5 and under early childhood age range. And everything below that arrow is going to focus more on our school age and teenage patients with CKD or kidney transplantation. So to get us started in that upper left-hand corner, so our early childhood patients in the pre-transplant phase, what research has really shown, most of this research has actually, it's been with the Bayley scales of infant development. For those that are less familiar with this measure, it has a mean score of 100 and a standard deviation of 15, as you're looking at some of those numbers that I put up there. But overall, in early childhood, for both infants and preschoolers, you see broadly average abilities pre-transplantation, although samples showed higher rates of kind of global developmental delays compared to normative groups, so 20 to 25%. We also see kind of worse outcomes in these infants and preschoolers who are receiving dialysis leading up to transplantation. In that post-transplant phase, there is very limited research in this age range in the post-transplant phase. One study did show some evidence for improvement 14 months post-transplant in infants with a 14.4 point increase again on the Bailey. So again, this is very preliminary. It's a single study, but maybe potentially suggests some ability for earlier intervention with transplantation to be potentially protective against long-term cognitive difficulties, although again, really needs to be kind of confirmed in larger sample sizes over time. So now focusing a little bit more on our school age and teenage patients with CKD. Research in this population has shown kind of mixed findings of intellectual skills, but kind of average rates in the low average to average range. Although there are higher rates of impairment on kind of full scale IQ testing and academic testing compared to healthy samples or sibling samples. We also pretty consistently see attention and executive function challenges in a pre-transplant CKD patient population with higher rates of ADHD compared to the general population. The post-transplant kind of phase, one study did look at changes in functioning from the pre-transplant to post-transplant in CKD patients. And what they saw is some evidence for improvement in functioning from the pre to post-transplant phase, as I have kind of shown there. Although kind of overall, we're still seeing full scale IQ scores falling in more of that kind of low average range for this patient population. We continue to see academic difficulties in the post-transplant phase that doesn't actually necessarily improve and really looks similar to those on dialysis in the pre-transplant phase. And again, those higher rates of ADHD kind of persist post-transplant. Okay, now switching gears a little bit and talking about liver failure and transplantation. I will also start here with what does our liver do? So a lot of the blood leaving our stomach and our intestines passes through the liver. The liver processes the blood to remove toxic substances and then can break down and create different nutrients with those substances, or can do things like metabolize drugs to make them or kind of put them in easier forms for the rest of the body to use. So when we do have liver failure, what happens is there's a buildup of these neurotoxic substances or metabolites in the body, especially in our blood. And this is particularly ammonia is one that we think about with liver failure. And this is called hyperammonia when there's kind of excess ammonia circulating in the blood. And again, this can have direct implications for the brain and central nervous system. What research has shown with this kind of hyperammonia is alterations in different metabolic processes and neurotransmission, increased rates of oxidative stress, as well as increased rates of brain swelling. There is also kind of a more common neurological complication that can happen with liver failure, and this is called hepatic encephalopathy. So this is a very serious but often reversible finding that is common in pediatric patients as well as adult patients, but I know our focus today is pediatrics. So some research has suggested that kind of up to 40 to 50% of pediatric liver failure patients will experience hepatic encephalopathy. So this happens when there's a buildup of toxic substances in the bloodstream, especially ammonia, and this impairs excitatory neurotransmission in the brain. So this can result in seizures, but also changes in cognitive, language, and motor function, with some of those motor findings being things like ataxia, a slowness of movement like bradykinesia, and nystagmus. Another kind of key factor to consider when seeing patients, pediatric patients with liver failure, is malnutrition. So this is really kind of a staple outcome of chronic liver failure, but can also be seen in acute liver failure as well. And this leads to kind of downstream low weight and poor growth. They all kind of tend to hang or occur together. And there's some kind of early research to suggest that maybe this malnutrition status can be increasing risk for cognitive and neurodevelopmental difficulties too. So maybe is there kind of this key, is malnutrition kind of this key moderator between liver failure and cognitive or neurodevelopmental outcomes? And if we really focus on nutritional intervention early on in organ failure, can this kind of prevent or mitigate someone's risk for cognitive difficulties long term? Again, this is very preliminary, and there's a lot more to be studied here to kind of solidify it as a key risk factor in this patient population or interventional target. Okay, talking a little bit now about kind of etiologies of liver failure and liver transplantation more broadly. So of all liver transplants in the US, pediatrics accounts for about 8%. And what we've really seen is increased rates of liver transplantation in pediatric patients due to advances in different kind of donor types in recent years. So one of these are going to be living donors. So this is when a healthy adult donates part of their liver to a patient with end-stage liver disease. And the donor's remaining liver regenerates and it grows back to its normal size and function within a few months. But then they're also able to give part of their liver to a pediatric recipient. The other is called a split liver graft. So this is all from a deceased donor. So this is when a single adult deceased donor's liver is divided and transplanted into two recipients. So typically one is an adult recipient who receives a larger portion of the donated liver, and then also a pediatric patient who receives that smaller portion of the liver. So these kind of advancements in liver transplantation have really curbed a very serious shortage of available livers for pediatric recipients because there's so few pediatric donors, and liver transplantation is primarily occurring at a very young age, so about 65% occurring in children yet less than 5 years old. There are a variety also of medical precursors to liver failure and liver transplantation. The most common is biliary atresia in pediatrics. So this accounts for about 40% of all liver transplants. But there's also different kind of liver specific diseases or underlying genetic and metabolic conditions like Wilson's disease or urea cycle disorder. You can also see primary liver tumors in young children. But there's also acute liver failure, which is often due to things like infection or metabolic disease that can lead to liver transplantation. So this graphic is going to be just the same as what I used before within our kidney transplantation slide. So again, I have that arrow going across the middle that looks at kind of pre-transplant outcomes on the left-hand side and post-transplant outcomes on the right-hand side. Anything above that arrow is focused on our 5 and under population, and then anything below is our school-aged and teenage population. So again, starting in our top left, what we see pre-transplant for kind of most of this research has been done in infants at 1 year old. What we see pre-transplant for those experiencing typically chronic liver failure is average to low average cognitive and language abilities. These are grouped together because the Bailey grouped them together in older versions. So most of this research is with the Bailey too. And so those cognitive and language difficulties are again kind of falling in that like average to low average range. And then we see kind of low average motor skills again at that 1 year mark. In the post-transplant phase, we see similar outcomes with kind of average to low average scores in that cognitive and language domain. But we also see higher rates of impairment overall and developmental delays overall compared to normative samples. There is one study that showed stable or modest improvement in functioning in those transplanted before 2 years old, compared to a decline seen post-transplant in those transplanted after 2 years old. So again, maybe some suggestion here or that there's benefit to earlier intervention due to reduced duration of liver failure and its impact on the central nervous system. Okay, now focusing a little bit more on our school-aged and teenage patients. What we see is low average to average overall full-scale IQ scores in the pre-transplant phase, with worse outcomes in those with what's considered chronic liver failure compared to acute liver failure. And this is thought to be because those that experience acute liver failure had kind of typical functioning. They didn't have liver dysfunction prior to liver failure that was progressive or long-term. And so they didn't have as much impact, again, to their central nervous system over time. So outcomes in chronic liver failure patients tend to be worse from a neuropsych and neurodevelopmental standpoint compared to those with acute liver failure. In the post-transplant phase, what we see is kind of a downward shift in our bell curve or IQ scores with a higher percentage showing kind of IQ scores in a range concerning for intellectual developmental disorder or IDD. But those kind of group average scores or mean scores fall in the low average to average range for full scale IQ overall. There's been a little bit of research looking at differences in the pre to post transplant phase for full scale IQ, but really show kind of stable weaknesses across both that don't change over time. We definitely see higher rates of learning and academic difficulties across subjects in this patient population. There has been some research that have looked at other domains like executive function, visual spatial abilities, attention, and have seen some difficulties or differences in those areas too. But these have been pretty limited. So we don't have a really kind of clear understanding of a profile for this patient or really what kind of key or characteristic difficulties there are outside of full-scale IQ scores and academic challenges. Okay, and then the last population that I'll talk through is heart failure and transplantation. Um, Kind of heart dysfunction or cardiac dysfunction isn't necessarily something that's totally unheard of or new to pediatric neuropsychology. Many providers see patients with what's called congenital heart disease in their clinic. And so I don't want to overly focus on CHD here, and I will kind of refer people to this paper here, which is Congenital Heart Disease, a primer for the pediatric neuropsychologist. This came out in 2018 and was written by Adam Cassidy and others. And this really breaks down what congenital heart disease and its various subtypes are and what the kind of implications are from a neuropsych perspective. And so that's going to be a much more in-depth review of congenital heart disease in general. So instead here, I'm going to really try and focus on CHD patients among other types of patients that experience heart failure, because this is what leads to heart transplantation. So to just take a step back there, what does our heart do? It continuously pumps oxygen and nutrient-rich blood to the body and then delivers waste products like carbon dioxide to the lungs to be removed. There really is two kind of main sets of populations that experience heart failure, one being CHD, or again, congenital heart disease, and then the other being cardiomyopathy. These really are kind of both umbrella terms that describe different kind of subtypes of each of their own categories. So CHD is the most common birth defect in the US, and it occurs in 1% of all births in the US, so about 40,000 infants a year. 25% of those are born with what's considered critical CHD. So this is a group of heart defects that cause serious life-threatening symptoms and typically require surgical intervention within the first few days to months of life. Most causes of CHD are not known, but about 15 to 20% are thought to be genetic. Where cardiomyopathy, on the other hand, is a group of disorders or diseases of the heart muscle. So this can be present as typically like enlarged, thickened, or stiffened heart muscles. Some people can be asymptomatic with cardiomyopathy, but for many infants and children, this can progress very quickly. And essentially, the heart can become so weak that it can't properly pump blood, which then results in heart failure or arrhythmias and may progress to transplantation. So again, kind of two different buckets of categories of disorders with different subtypes under each, but they kind of all converge in that they can lead to heart failure. So the next couple slides, I'll talk a little bit about heart failure and how it impacts the central nervous system. So I'll talk mostly about CHD on this slide, cardiomyopathy on the next slide, but really, again, they converge at heart failure. And with any type of heart failure, regardless of etiology, what you have is suboptimal perfusion and oxygenation of the brain. For patients with CHD, this is really thought to start in utero. So as the heart is developing abnormally, the brain then starts to develop abnormally because of this suboptimal perfusion and oxygenation. And this is as early as the second trimester. Like I mentioned before, these patients often undergo surgical intervention kind of again within the first few days of life or months of life. But even kind of in that pre-surgical phase, what we see are differences on neonatal MRIs with a notable impact to white matter structures and volumes. And then again, these patients undergo surgery very quickly, but also can undergo repeat surgery over kind of the first several years of their life. And so their surgeries, as well as something called cardiac catheterization, which is a procedure that they undergo intermittently to monitor heart function and status over time. Both of those place them at higher risk for cerebrovascular injury through mostly like ischemia through cardioembolic processes. But it also is and shows increased risk of like anesthesia for surgery and increased risk to noxious hospital environments, all with combined with the other things I talked about, posing risk to cognitive and neurodevelopmental function over time. So on this next slide, I'll talk a little bit more about cardiomyopathy. Although less is really kind of known about cardiomyopathy from a patient population standpoint and its impact on brain function. But what some preliminary work has shown is some changes in both gray matter and CSF volumes, as well as disruption or reductions in areas that are known to be critical for various cognitive functions that I have listed here in this yellow square. Definitely for cardiomyopathy patients, but also for CHD patients too. We always want to be thinking about their time on any external devices like ECMO or ventricular assist devices. So these are kind of life support type therapies that can take over the heart and lung function for a patient, but they also can increase risk for challenges with cognitive function and then increase risk for cerebrovascular injury as well. So this slide looks really similar to the other ones that I showed for kidney and liver failure and transplantation, but it's a little bit different. So I still have that same arrow going from pre-transplant to post-transplant phases through the middle. But this time in the top row, I'm going to be talking about outcomes in CHD populations. And then in the bottom row, I'm going to be talking about outcomes in cardiomyopathy patients. So starting with CHD in our pre-transplant phase, so this is often post other surgical interventions, but is pre-transplantation. So what you see are delays in motor and cognitive and language skills, but this really can vary by CHD subtype. So some subtypes have kind of more mild changes. So when looking at kind of full scale IQ scores, some mild subtypes, you might see a 2 to 5 point IQ reduction or difference in kind of more milder forms of CHD, but in more kind of severe forms like hypoplastic left heart syndrome, you might see as big as a 12 point difference in overall or full scale IQ score. We also see more consistently higher academic difficulties and higher rates of ADHD with attention and executive function challenges in this patient population. More broadly, again, all kind of pre-transplant. In the post-transplant phase, we see kind of low average to average IQ scores, again, with a higher percentage showing kind of more impairment compared to the normative sample. Cognitive difficulties can be seen across a variety of domains, again, with kind of academics, attention, and executive function being the most consistently shown. And what we see is that kind of worse post-transplant cognitive functioning is related to worse pre-transplant disease severity. So suggesting kind of greater heart dysfunction or failure with more impact to the brain and then cognition overall. For cardiomyopathy, we don't have a ton of data on pre-transplant functioning, but this is thought to be superior to congenital heart disease patients due to normal heart function with no impact to the central nervous system prior to the onset of cardiomyopathy, which then results in better post-transplant outcomes as well, just because the duration of that heart failure overall is much shorter over time. So just to pause for a quick second, I know I talked through a lot of information, and I'll give a little bit of a summary before kind of moving on. So again, this patient population or patient populations has a literature base that uses really kind of heterogeneous methodologies, and it's really hard and difficult at the state of the literature right now to compare studies both within and across organ groups. So kind of limits our understanding of what, again, kind of cognitive profiles or prognosis looks like for this patient population. But what we do consistently see is that there are cognitive difficulties that emerge pre-transplant for many patients, suggesting that the primary cause of neuropsychological difficulties is the impact of organ failure on the central nervous system's function, rather than anything to do with the transplant process itself. We somewhat more consistently see a pattern of that those with chronic organ failure rather than acute organ failure have worse outcomes due to a longer time period of organ dysfunction impacting the central nervous system. And then there's also some maybe early preliminary data to suggest that there could be some improvements or stability in cognitive outcomes post-transplant. But the reason for this isn't entirely clear. Does this have to do with kind of timing of transplant and early intervention? Or does this have to do with like secondary improvement in other areas, like improved fatigue, reduced pain, overall well-being in the post-transplant phase that can, one, not only kind of impact how kids do on our testing, but also impact how much they are gaining from their developmental therapies or school-based interventions and resources like that. So a lot still to kind of unpack. I know we've talked a lot about different kind of organ specific risk factors, which I have kind of on the left side here. But I also want to take a moment to talk about some more kind of shared risk factors from a cognitive standpoint. So everything on the left-hand side of this graphic is really the things we just talked about. So each kind of organ group and their specific kind of pathophysiological processes and complications that have or pose risk for neurodevelopmental and cognitive outcomes. But on the right-hand side, these are things we have not talked about yet. So these are kind of shared findings or things that we are seeing consistently across research in different organ populations. So in that pre-transplant phase, those that are at higher risk for cognitive and neurodevelopmental difficulties include those that have a younger age of onset of their kind of medical precursor or organ failure, those that have greater disease severity, those that waited longer for transplantation, again, kind of more time for organ failure to be impacting the central nervous system, or those that have kind of certain comorbid diagnoses, especially genetic and metabolic disorders that pose their own kind of separate risk for developmental delays or disabilities outside of whether someone experiences organ failure or not, and those that come from lower socioeconomic status households. In the post-transplant phase, some more common or shared risk factors include anything that indicates that things are more complicated. And so a longer hospital admission post-transplantation indicating a harder recovery, or anything that alludes to any neurological complications. So known complications itself, like stroke or seizures, but also any abnormalities on imaging. Okay, so the next bit that I will dive into are some preliminary recommendations for care services, neuropsychological care services over the kind of transplant process. And this came from an article that myself and others published last year, focused on the role of pediatric neuropsychology. And this is, again, preliminary guidelines with the information that we have from research now, but should evolve over time as more research emerges in this patient population. So I'll show that we did is we conceptualize kind of relevant time points for neuropsychological care into three different buckets. So the first being the acute pre-transplant period, and then the acute post-transplant period, and then long-term follow-up more broadly. And I'll talk about each of these. So this acute pre-transplant period. So this can be an ideal time to establish a pre-transplant baseline or get a baseline evaluation that can be helpful for monitoring function over time, but also can be helpful for informing services and referrals in that pre-transplant phase. Like I talked about, people undergo this kind of transplant workup and are put on a wait list, but the time from being put on the wait list to receiving their transplant can be really variable. And so we want to make sure kids are kind of maximizing their supports and services for development at this time as well. So this can include for younger kiddos, things like early intervention and making sure kids are getting the right developmental therapies like speech language, OT, and PT. While they're kind of outpatient, but also when they're inpatient too, because many are kind of in and out of the inpatient setting during this time period. For our school age patients, this can include things like establishing hospital homebound services while maybe they can't go to school, and helping get some supports in place for accessing academics in the hospital as well. What we can do again for some of our older patients, or what we can do too, is support kind of medical decision-making involvement or concerns related to the listing process. And I'll talk a little bit more about this on a future slide, but this becomes really important for patients that do have kind of concerns for an established diagnosis of IDD or intellectual developmental disorder. So as recent as 2011, several organizational guidelines for solid organ transplantation include IDD or developmental disability as a contraindication to transplantation, and suggest that the benefits for these patients may be less meaningful than those with kind of typical cognitive functioning or less cognitive delays. And some surveys in US transplant centers showed that 43% of transplant centers always consider IDD as a listing criteria without actually having any formal process for determining an IDD diagnosis or status. While most others reported that they sometimes use that diagnosis as a factor in their listing process. Research has really shown that patients with IDD show similar improvements in quality of life pre and post transplant compared to those without developmental disabilities. And as neuropsychologists, we're really in a great position to advocate for these patients and help their medical team understand that improvement in health status and elimination of disease are all kind of reasons for improved quality of life, regardless of cognitive ability, or help them understand kind of what that change in quality of life might look like compared to somebody without a developmental disability. Doing testing in this acute pre-transplant period can have a lot of barriers. So again, patients are often inpatient. And we know that there's a lot of threats to kind of the validity of our testing in the inpatient setting. But it can also be hard to navigate kind of fitting in an assessment with time constraints. So again, sometimes that kind of wait list placement and transplantation occur really quickly. And so you don't have a ton of time to fit in a full assessment. And also patients can be tired and pain and not feeling well. And all of that can impact testing as well. We really encouraged neuropsychologists to consider alternative assessment methods if testing is just not feasible in this acute pre-transplant period, like getting kind of an in-depth clinical interview with a parent or using standardized questionnaires to understand pre-transplant function and then monitor function over time. So that monitoring comes up in our acute post-transplant period. So for many of these patients, they are spending time nearby the hospital, so in proximity to the hospital if they don't live near the hospital, due to the frequent need to be at appointments and get continuous monitoring in their initial recovery from transplantation. So if they're from out of state or from a further drive away, they often need to stay closer during those first kind of about 3 months. And so most of the time that 3 months corresponds with the ability to go home and school reentry. So it can be a nice time to get a kind of post-transplant baseline evaluation to really inform school reentry services for a patient and family. Again, for younger kiddos, this can include things like thinking about early intervention and developmental therapies. But for older kiddos, we want to think again about that school reentry process and any accommodations or interventions that are needed there, as well as any supports for reintegrating back into normal life, including psychosocial care. We can think about any kind of impact of cognition on a new medication regimen at this time, again, which I'll talk about in the next slide. But it can also be challenging to do testing in this acute post-transplant period as well. So some of those same players are there. Patients may be fatigued or in pain or have sleep changes after being in the hospital for such a long time that just make it not a great time to do testing or get valid results. And again, patients might be kind of only near the hospital for a few months before being discharged home. So kind of similar challenges and alternatives can be used in this acute post-transplant period as well. And then that last kind of bucket or endpoint is long-term follow-up care. And so we really recommended focusing this long-term follow-up care in a similar way to how we think about it for other patient populations too. So focusing on evaluations around major transition periods like transition to middle school or transition to adulthood. But also partnering with pediatric psychologists for cognitive screening can be really helpful. These providers are typically very embedded in the multidisciplinary teams and clinics at transplant centers. And so they may be able to help with kind of screening and then referring in timely ways that are a little bit more tailored to patient needs over time. And again, these long-term follow-ups are just like our typical follow-ups. So they can provide updated recommendations for academic, occupational, psychosocial functioning, all of the above. Okay, and then my last little bit here for this presentation is just thinking through some special considerations for care when working with this patient population. And I've alluded to a couple of these, if not all of them already. So one is going to be in that medical decision-making realm. And so this is kind of a little bit more obvious in the pre-transplant phase. So there's kind of a big medical decision that's being made around kind of timing of transplantation, alternative treatments, et cetera. But these patients often experience a lot of kind of medical complexities, even post-transplant. So there's different kind of post-transplant complications that they have to manage, like graft rejection, PTLD, even end-of-life care, or different kind of infections and medication changes over time that really make medical decision-making and medical decision-making involvement for our teenage patients more kind of important and an area of focus. For neuropsychology, we do a great job of understanding a patient's kind of cognitive areas of strength and weakness, and even strengths and weakness beyond cognition. And we use this to inform a lot of compensatory strategies for things at home, school, on the job, etc. But for this patient population, we might want to think about how those strengths and weaknesses can impact their interaction with the medical team and when undergoing or participating in any medical decision making. So for example, for those that have kind of more broad-based intellectual impairments, we might want to work with the team to help set up some more accurate and meaningful scripts around kind of medical education that is developmentally tailored to a patient's kind of cognitive status or developmental status. Some patients might experience, say, visual spatial difficulties, which means that any kind of visual aids a doctor is using to demonstrate what surgery is going to be, or graphs for charting lab values might be harder to interpret. And so we might suggest things like using written language for communication or explanation. Academic difficulties, as you saw, were highly prevalent across all organ types, and this can certainly impact someone's ability to manage their own kind of medication regimen over time. So for something like dyslexia, a patient might have a harder time understanding written instructions for a medication regimen, or like reading text on a bottle with warnings or things that are important for timing and dosage of medication. Also, math difficulties can impact things like calculating out dosages or kind of estimating time in between dosages as well. This kind of brings me to my next slide here, which is this medication adherence piece. So kind of a part of medical decision making, but separate and unique all at the same time. These patients are on lifelong immunosuppressant medications that require extreme timeliness. So consequences of missing a dose or being late on a dose can be really dire. It can include things like graft loss and mortality. And again, these are lifelong daily medications with very strict timing schedules. So it might be things like exactly every 12 hours apart, and patients may need to call their medical team if taken even a few minutes late. So these patients have to be very vigilant for dosage timing and prescription refills long term. What we see is that in the kind of adolescence time period, there are higher rates of medication non-adherence. This is a time where caregiver involvement is decreasing and teenagers are becoming more and more kind of independent and responsible for their own medications. And we can see this difficulty with managing medications in this time frame, regardless of when they received their transplant. What research in this area has shown is that executive function deficits are related to increased risk for non-adherence, especially things like task initiation and monitoring, planning, and organization skills. Executive function deficits are highly relevant to this patient population too, as I've talked through. So we are really kind of posed to be in a good position to provide education to the family members or family members and patients around what executive functioning is, how this might be impacting kind of their medication regimen, and what are some compensatory strategies that can help with adherence, things like pill boxes, reminder systems, or different smartphone applications like I have here on the right-hand side that can all support medication adherence. It's also important for us to be aware of psychosocial impacts of the transplant process, like increased mood and anxiety symptoms, and how emotional and functioning can impact medication management as well, especially in that adolescence timeframe. And then the last special consideration is this transition to adulthood. So this transition period, so adolescent young adult or AYA timeframe, actually shows the highest rates of organ rejection, which again could be related to non-adherence. What we also see in this patient population is that regardless of cognitive status, there are adaptive challenges, including lower rates of educational attainment and employment. The American Academy of Pediatrics really recommends beginning the transition process around 12 years old, but we at least want to consider doing an evaluation prior to the patient reaching legal adulthood. It can be helpful for us to think about strengths and weaknesses and how this impacts things like educational and vocational goals and independent living over time. We'll be able to provide recommendations around accommodations on the job for those entering the workforce. For patients with more kind of broad-based or intellectual impairments, we want to think about power of attorney or guardianship around this time period. And that's why it's helpful to do an evaluation before they reach legal adulthood at 18 years old. The pediatric psychologists that are often involved in the multidisciplinary kind of team do a great job of some of this transition readiness monitoring, but not everyone may have access to a pediatric psychologist at their center. And so there are several tools that can help with tracking transition to adulthood preparedness in solid organ transplantation specifically. And so I have some of those listed here, but it can be also helpful to partner with pediatric psychologists to time assessment if they are involved in tracking some of this transition readiness. And then for my last slide here, I just want to give a quick summary and some future directions for this population. So we know that solid organ transplant recipients demonstrate kind of mild to moderate neuropsychological difficulties across several domains that are often evident prior to transplant. These difficulties pose substantial consequences for things like health management, social emotional functioning, and quality of life over the lifespan. What we really need to do is expand research to larger sample sizes, including longitudinal designs with both pre and post transplant assessments and cross organ samples. And with that information, we can then establish better guidelines within multidisciplinary working groups to make easier kind of avenues for care advocacy and timing of care across the board. So the last bit here, I just want to say thank you to some other collaborators that have worked with me and mentors in this patient population, and that contributed to kind of there's an article out there that this group published on preliminary guidelines for neuropsychological care in pediatric solid organ transplant. That's a great reference, but I want to thank all of them, in particular Kelly Wolf, who was a mentor for me in this patient population. So thank you.
Thank you, Dr. Turner, for that excellent presentation, and I will definitely be checking out that article very soon. So thank you all for joining us as well. Please join us again next week for the pediatric neuropsychologist's role in epilepsy surgery, clinical care, and patient advocacy presented by Dr. Rosalia Costello. Thank you again, Dr. Turner, for your presentation, and thank you all for listening.